Lymphocytic leukemia, to be presented by Dr. Jeffrey Jones from Columbus, Ohio. Evaluation of 243 patients with deletion 17p, the poor prognostic subgroup, treated with ibrutinib. Cross-study analysis of treatment outcomes. Dr. Jones.
Columbus, or the Paris of Ohio, I like to think of it. So I thank you for the opportunity to present results of an integrated analysis across several trials enrolling deletion 17p patients with chronic lymphocytic leukemia. So while chronic lymphocytic leukemia is generally considered an indolent lymphoid malignancy, prognosis is quite heterogeneous, and patients with deletions of chromosome 17p in particular experience a relatively dismal prognosis historically. Historical data suggests that those patients live only 2 to 3 years beyond the initiation of therapy. So ibrutinib, a first-in-class oral once-daily inhibitor of the Bruton's tyrosine kinase, is a therapy with marked activity in deletion 17p CLL that allows for treatment of the disease without utilization of chemotherapy. The drug is now approved in both the US and Europe for various CLL and small lymphocytic lymphoma indications, specifically including patients with deletions of chromosome 17p. So this integrated analysis tries to provide a more robust estimate of clinical outcomes among ibrutinib-treated patients with deletion 17p CLL. So three large multi-center trials were included in the analysis, and we limited the analysis to patients with deletion 17p identified by fluorescence in situ hybridization, a very standard technique. 243 patients were included, all of whom received once-daily oral ibrutinib. The majority were treated at the now standard dose of 420 milligrams daily, with a smaller number, only 11, treated at a higher dose of 840 milligrams. As in other studies of ibrutinib, all patients received treatment until progressive disease or until discontinuation for unacceptable toxicity. The primary endpoints of this analysis were the overall response rate and survival endpoints, both progression-free and overall survival, as well as severe, that is greater than 3 or greater adverse events of specific clinical interest. At the time of this analysis, the median time on study was 28 months. The key findings of our analysis are demonstrated here. First, in the panel on the right, you can see that an overall response was achieved in 84% of patients, including a minority, 9%, who achieved a complete remission. At 30 months of follow-up, an estimated median progression-free and overall survival had not yet been reached. At that 30-month time point, 55% of patients remained progression-free, and 67% of patients remained alive. Again, with a median time on study of 28 months, in this group of 243 patients with high-risk CLL, all of whom had deletion 17p, the estimated 30-month progression-free and overall survival surpass those reported for all other existing therapies for deletion 17p CLL. Overall response rate was consistent across studies, approximately 84% in all of the studies included here. Finally, with respect to adverse events, the severe adverse events declined over time, and only 15% of patients discontinued therapy because of an adverse event. At the time of the analysis, 45% of patients remain on study treatment with ibrutinib.
Is that it?
That's it.
Is that it?
That is it.
I thought so. Thank you very much. Questions from the journalists, please?
It's a one-horse show, I guess. Could you ever envision, from what we heard earlier about the about tyrosine kinase inhibitors, could you ever foresee a time when patients would go off the drug? Or?
Potentially. Although it seems unlikely in this case in the majority of patients, particularly in higher risk CLL. In a subset analysis that I'll present tomorrow afternoon, It's clear that patients receiving ibrutinib earlier in their disease course appear to have better survival outcomes. Across the board, the depth of response appears to be greater when ibrutinib is utilized earlier in the disease course. So in the initial study, Pharmacyclics 1102-1103 study, at 3 years, approximately 20% of patients, including some with deletion 17p, had achieved a complete response. So that suggests that earlier initiation of therapy, may be of help. But at this point, because the depth of remission does not appear to be the same as that achieved, say, with the TKIs for CML, it seems unlikely that a single agent TKI kinase inhibitor will be successful here, at least to that end.
Thanks.
Although you indicate a dramatic overall response rate, 84%, the CR rate is only 9%. So what are the current explorations to increase that? I mean, to add a cell-killing agents like anti-BCL2, what are the current explorations to get those curves to a plateau, because they go down?
Right, so there are two ways that I think investigators are considering the problem. One is a model that looks at long-term disease control without a specific goal of discontinuation. And one of those could be sequential single agents, interrupted therapy. As you've seen, the data, to the extent that it exists, suggests that interruption of ibrutinib and subsequent restarting in the absence of resistance can be successful. Alternatively, combinations of novel therapies are being explored. The one I think that's of greatest interest is in combination with the BCL2 inhibitor recently approved in the United States, venetoclax, again approved specifically for the deletion 17p investigation. Our group, as well as others around the world, are keenly interested in that combination, since venetoclax appears uniquely able to improve bone marrow disease, which is often where patients treated with ibrutinib fail to achieve complete remission.
Thank you. Any further comments, questions?